Okay. Hi, everybody. I'm Dr. Ramzi Asfour. I'm giving this presentation in conjunction with Dr. Dost Sarpel. We are the infectious disease doctors that run Capsid Consulting. We wanted to talk about some hot topics in infectious diseases for doctors, mainly doctors and healthcare providers working in skilled nursing facilities. And we've got a lot to talk about, so let's get going. So Capsid Consulting is a company that I founded actually, well, we've in some form about 9 years ago. After I've worked in multiple skilled nursing facilities, actually I've worked in 30 different skilled nursing facilities as an infectious disease doctor, seeing patients with a team of other infectious disease doctors and nurse practitioners. We worked closely with nursing staff and infection preventionists on site, but we were mainly focused on patient care at that time. And we were asked to start helping out with antimicrobial stewardship and infection prevention. And that's what we focus on. We focus on infection prevention, antimicrobial stewardship in the long-term care settings. So we provide many services. We've been working with skilled nursing facilities since way before COVID, and we do educational webinars like this one. We provide a monthly teleconsulting meeting with the infection prevention team. We help with standardized treatment algorithms for common infections and when to treat so that we minimize unnecessary or inappropriate antimicrobial use. We help with outbreak support. We help with improved patient outcomes and decreased operating costs. We also help prevent tags. And in fact, in the past 2, 3 years, actually, since we were founded, we have our clients who are working with us with the monthly meeting protocol that we have not had any significant uh, infection prevention citations or fines. There have been a few minor tags, but other than that, they've been doing really, really well, which is great. We're really proud of that. This is a sign I saw in a restaurant in Oakland, California, that I was just laughing at in the bathroom, of course, in the restaurant. And wash your hands as if you had just picked up dog poops with bare hands. Just remember that nobody knows how to wash their hands well, or if they do, they don't wash their hands well routinely. It takes time, 20 seconds, soap, scrubbing, and we're not doing that routinely. People don't do that. Even with alcohol jelly, you have to remember that you have to really rub it till it's dry, and we don't do that. And get it in between the fingers, and do a really good job. We need to always emphasize hand hygiene. I think that's the basis of infection prevention. Really, hand hygiene is so important. Talking about antibiotics, shorter is better. That's the new mantra of antimicrobial treatment in most settings. Shorter is better. Shorter, for example, for urinary tract infections, for pneumonia, a shorter course is better. So less antibiotics is more. A shorter course, believe it or not, will reduce the length of stay and has been proven to, of course, improve adherence, reduce toxicity, and reduce the risk of C. diff. So you are also reducing length of stay in the acute care setting. A lot of these studies were done in the acute care setting, but they apply to the nursing home setting as well because they're not being monitored in the acute care setting. They're also having fewer side effects, a lower incidence of C. diff, and reduced toxicity. So this is really, really important, and we're going to go over guidelines for duration in this talk. Um, so the IDSA guidelines on management of community-acquired pneumonia said that CAP should be treated for a minimum of 5 days. I would generally say uh, average duration should be 5 days. The patient should be afebrile for 48 to 72 hours and not be unstable before you discontinue therapy. And then a longer duration of therapy may be needed if the initial therapy was not active against the identified pathogen. For example, if you have Staph aureus and you weren't treating with a regimen that covers Staph aureus, and you had a Staph aureus pneumonia, which isn't that common, but it does happen, then you would restart the clock and making sure you didn't have any other complications such as endocarditis or bacteremia or meningitis. This is a chart of antimicrobial susceptibilities. This is something that we get a lot of questions on because they would say, Dr. Asfour, well, this one says less than 0.5 and this one says less than 4. So this one less than 0.5 must be better. That is not true. These are not comparable because this is it's a different number for every antibiotic. So you really can't compare. It's like comparing apples to oranges. One uh, way to think about it is it's maybe different potency of uh, like different steroids, for example. Prednisone versus dexamethasone. 1 milligram of dexamethasone is equivalent to 4 or 5 milligrams of prednisone, for example. They're not identical. And same thing here. Just don't compare the actual number. The only thing you should be looking at is S or R. And if you see I, that means intermediate. So please don't get hung up on the numbers saying one antibiotic is better than another because of the numbers. There are a few nuances. If you have questions, certainly reach out to us. We'll be happy to help. So antibiotic duration, shorter is better. Here's another study talking about community-acquired pneumonia. Randomized at day 5 to stopping antibiotics if clinically stable. 30-day rates of clinical success were higher for short course. Okay, 93% success for short course versus 80% for longer course. Readmission rates were lower for short course versus long course. 1.4 versus 6.6% with a p-value of 0.02. That's a very impressive result, right? So shorter is actually better. That's really, really important to keep in mind. And that helps us with antimicrobial stewardship, which is one of the big things that we help our facilities with. We help generations with. Super, super important to remember. Oops, sorry. To remember that. So, we're no longer using the term HCAP. We're using local antibiograms to reduce unnecessary double coverage for GNRs and MRSA. We're de-escalating quickly and short course therapy for everyone, 7 days, regardless of the organism. So this does not apply to TB. There are a few exceptions, but we're talking about community-acquired or hospital-associated pneumonia. So these are the IDSA guidelines for skin and soft tissue infections, 2014 versus 2010. So they used to say 5 to 10 days. Now, 5 days, cellulitis. You can extend if no improvement within 5 days. But remember, in 5 days, you're not going to see complete improvement. You're going to see, there might be still a little bit of residual redness. I tend to stop at 5 days. I'm doing my best to stop at 5 days. Abscesses, carbuncles, furuncles, these are surgical diseases. These need to be debrided, lanced. Sometimes they're small. You can do it in the nursing home. Sometimes you need to send them to a surgeon. Recurrent abscesses, weak evidence. These are people who have, sometimes they have staph or MRSA carbuncles or MRSA folliculitis or furuncles. These are challenging to treat. I treat them with a decolonization protocol often, and not just with antibiotics, and not really with antibiotics actually. So shorter is better and the guidelines reflect this. The here is acute bacterial skin and skin structure infection, 6 versus 10 days. This is using tadazolide, which is a cousin of linezolid, and they basically found that 6 days of therapy with tadazolide was as effective as the 10 days of linezolid. So this was pretty impressive. What actually happens though? So multi-center retrospective evaluation, antibiotic prescribing for, this is in hospitals, skin and skin structure infection. These are very common infections in nursing homes. Duration is more than 70% of people get a duration greater than 10 days. A lot of people get duration greater than 14 days, and unnecessary gram-negative coverage in 42%. I can't tell you how often I see Vanco and Zosyn for skin soft tissue infection. I don't see it in nursing homes as much. I think the providers there are more aware of using staph and strep coverage. It's sometimes it's okay to use two antibiotics such as doxycycline plus amoxicillin, doxycycline for MRSA or Staph aureus, the amoxicillin for a strep. That's a nice combination. You can use Keflex and amoxicillin, sorry, Keflex and doxycycline or Keflex and Bactrim as well. But those are all options. Or you can use, if you're not worried about MRSA, if the patient has no MRSA history, you can use dicloxacillin or Keflex, cephalexin instead. Okay, UTIs. Were you taking over here, Dr. Sarpel? Or was I doing UTIs? Sorry, I forgot.
Hi, everyone. Sorry, can you hear me? Good. So I'll be taking over UTIs and essentially going to be continuing what Dr. Asfour has been saying about shorter treatment. Obviously, UTIs are a big problem in skilled nursing facilities, as is bacteriuria, asymptomatic bacteriuria, and we see a lot of over treatment. But that can be a whole other presentation in and of itself. But again, shorter is better for treatment of UTIs. The old guidelines from IDSA are over a decade old. I went to a recent seminar not that long ago. You know, they are working on newer guidelines. Hopefully, they'll come out shortly within the next year. But, you know, if a female's UTI, 3 days, you can use Bactrim. If you're using Keflex or cefadroxil or some other beta-lactam, again, 3 days, usually enough. Occasionally, if they have a slow response, you can go to 5. Rarely do we go to 7 these days. Macrobid, which can be used in certain situations. That's the one time where you definitely need to go more than 3. Treatment with macrobid is 5. Men, again, 5 days is usually enough. They may need 7, again, depending on the response, but typically 5 to 7 days. Pyelonephritis, so if they have an infected kidney, the old teaching was 2 weeks, period, end of story. They get 2 weeks of antibiotics. Now that's being revisited. Usually, when we see someone with pyelonephritis, they're already having a delayed response and they're in the hospital and they're sicker. But so we will do 10 days, but if you catch it early enough, you can get away with 7 days. CAUTI is a whole other thing. You should know that we developed an algorithm for complicated urinary tract infections, including CAUTI. Your facilities have access to this algorithm. Most of the IPs have it. So again, the treatment there, number one, is change the Foley catheter. But again, shorter than what we used to think, 5-7 days. So here's a example of a treatment protocol. This is for cystitis, mainly uncomplicated. So again, looking at the top box, it's not just, their urine culture is positive, right? So they have to have clinical manifestations like painful urination, urgency, suprapubic pain, fever, flank pain. Obviously, you need to know whether or not they have a Foley catheter because that can change your treatment. And can they take PO meds? those are the things initially you should evaluate. If you could hit the next button. But I wanted to point out in the, the assessment, you know what's not on there? The color of the urine and the smell of the urine. That should not be used. You know, a lot of times we get calls, or patient gives a sample, the culture is positive, and they collect the sample because the urine smells bad. You know, a lot of things can make your urine smell bad. A lot of things can change the color and the consistency of your urine. That should no longer be used as part of your assessment. That is not in any algorithm. The other thing that's not in here, but I definitely want to mention, is falls. Like the number of times the urine is sent for someone who has a fall is innumerable that we see. And it should not, like, in the neurologists say it shouldn't be done. Infectious disease docs say it shouldn't be done. Geriatricians say it shouldn't be done. Like, so if your patient has a fall and they're not having any other symptoms, you should not be sending the urine sample, because invariably it will be positive, because half the people in skilled nursing facilities, especially women, have positive urine cultures. They have asymptomatic bacteriuria. They get overtreated. They have multiple problems that are associated with overtreatment. And so that is another thing that is not on the assessment. So if you can give an oral antibiotic, you can give macrobid, as I mentioned. You can give Bactrim for 3 days. A newer antibiotic, which is just one dose, is fosfomycin. It's actually very good for resistant E. coli. It's approved for that. And it's a powder. You mix it in some liquid and you drink it. It can be a little more difficult to get, but it's very effective. But if they're not having any of these symptoms, you shouldn't be sending the sample. And then if you could click the next button, I wanted to point out, so for alternatives, if they can't take macrobid or Bactrim for whatever reason, second-line agents are beta-lactams, so augmentin, so not amoxicillin or ampicillin, for the most part, should not be used alone unless you know they have a very sensitive Enterococcus fecalis or faecium. That would be the only time you would use it. But for E. coli, Klebsiella, whatever, you really wouldn't use it alone. But augmentin is fine. Cefpodoxime, which is Vantin, which is similar in coverage to ceftriaxone, Ceftonir, all those are good. You know what? So I've mentioned 5, 6 antibiotics. That's before you get to the quinolones. So quinolones should be like last resort. Ciprofloxacin, Levaquin, you can use them, but again, they're not the primary treatment. They're not even secondary agents. They're way down the list. So, and we'll discuss why in a little bit. But I wanted to just emphasize that quinolones should be avoided where possible. Next slide, please. So occasionally, patients with the UTI can develop bacteremia. And, the knee-jerk reaction is to start them on IV antibiotics and treat for 14 days. Again, this is sort of the old mantra for treatment. Many studies have come out since then looking at shorter course of treatment for bacteremia. Do we really need 14 days? This is just one of, again, many studies. Over 50% of the source of the bacteremia in this setting was either UTI or cholecystitis or cholangitis, and they looked at shorter course of 6 to 10 days versus 11 to 16 days, and they looked at all-cause mortality, and there was no difference with shorter course of treatment. And again, multiple studies have shown this, and now usually if it's just a simple bacteremia that responds quickly to antibiotics, fever goes away, white count goes away quickly, you can get away with 7 days of treatment. Maybe you extend it to 10 if there's a slight delay in response. Rarely do you go to 14 in this setting. And Again, old mantra treatment was with IV. New mantra is give orals when possible. Again, multiple studies have shown that oral treatment in most settings for simple bacteremia that's uncomplicated uh, is just as good as IV. Plus, again, you save nursing time because you save money because you don't need to get the IV set up. You don't need to put in a PIC line or a midline. The nurses can just pass oral meds and then go on and do everything else they need to do on the floors. They don't need to sit there and do an IV push over 10 minutes. So again, oral over IV, shorter over longer. And one of the things we do is a newsletter, and this was discussed in our newsletter, so you can check that out. Next slide, please. So what actually happens? So despite all this evidence, so this is another study looking at the VA, which was done back in 2014, and asymptomatic bacteria. So these patients don't even have a treatment, have an infection. They still get treated for 10 days, right? Just uncomplicated cystitis, well over 10 days. Pyelonephritis, 14 days. Like I said, the mantra was 14 days. So that's what they get. Caudy, 14 days. So that's what actually is happening. And but you don't need to do this length of therapy, and you definitely can cut it down where possible. Next slide, please. So again, just to summarize, just some of the infections where we are having more and more data that shorter is better. Dr. Asfour talked about community-acquired pneumonia as well as nosocomial pneumonia. He brought up a great point about aspiration. A lot of times patients just have an aspiration pneumonitis and don't even need antibiotics. But if they have an aspiration pneumonia, again, treatment's still 3 to 5 days, not 2 weeks. Intra-abdominal infections, bronchitis, sinusitis, cellulitis, which Dr. Asfour talked about, UTIs, which I mentioned, and then chronic osteomyelitis. You don't need to go 8, 10, 12 weeks. Again, there are certain exceptions, but in general, for simple, straightforward infections, a ton of evidence out there now that you don't need 10 days of antibiotics for everything, and you can get away with oral antibiotics. Next slide, please. So we talked about how shorter is better, right? So shorter antibiotics better for the patient, but quinolones, not so much. And we're going to talk about why. So next slide. So just a quick recap. This is the family. I'm not going to spend too much time on it, but the most common quinolones that we use here in the States are ciprofloxacin, which if someone has Pseudomonas, Cipro is the best. We're moving away from using Levaquin for Pseudomonas. It's just not as good. And CLSI just released some of their updated sensitivity data, again, moving away from Levaquin for Pseudomonas. So if a patient has Pseudomonas, give Cipro, and it's a higher dose. It's not your typical 250 for UTI or 500. You want to go higher. So for UTI, at a minimum 500, if not 750, if there's complicated infection or bacteremia. Levaquin is good for respiratory pathogens, and then moxifloxacin, which is Avelox, is actually very good for respiratory pathogens. It's actually very good for anaerobic pathogens, so it'd be a good option for someone who has an aspiration pneumonia, like an actual infection from an aspiration. Quinolone's not the best for skin and soft tissue infections, so just a regular old cellulitis. I'm not talking about sacral wounds or diabetic foot wounds or things like that. But they're just straightforward cellulitis. They're not the best. Next slide. So this is a great movie, Good, the Bad, the Ugly. I like to use this slide to talk about quinolones. Next movie. So quinolones are good. There are good things about quinolones. Their bioavailability is high. You can give it PO. It's great for osteomyelitis, prosthetic joint infections. It gets everywhere in the body. It's actually the treatment of choice for prostatitis. So it has great penetration. They're broad. As I mentioned, they cover Pseudomonas as well as a bunch of other gram negatives and also some gram positives like strep. Easy to dose. So there are reasons why you use them, and there are reasons why they became so popular. Next slide. But unfortunately, we're learning this more and more and more. Resistance is increasing. There's a ton of drug-drug interactions. It can affect coumadin levels. That causes electrolyte abnormalities. If you give it with NSAIDs, it can lower your seizure threshold. It can cause drug-induced liver injury, and it can cause QTC prolongation in combination with other medications. So if you're using Cipro or moxifloxacin on their own, probably totally fine. But if you're also giving like fluconazole plus trazodone plus they're on amiodarone, then that's when you really need to worry. Next slide. But most importantly, it is the number one associated antibiotic with C. diff, which is a problem, obviously, in healthcare facilities. So again, was one of the biggest reasons we're trying to move away from quinolones. We're starting to see tendinopathy or tendon rupture, particularly in the population that are in skilled nursing facilities, so age greater than 60, who happen to be on steroids. That also increases the risk. Can cause aortic dissection, can cause neuropathy. It's rare, but it happens, and it's irreversible. And actually, what's probably the most, outside of C. diff infection, the most common adverse event with quinolones in the population in skilled nursing facilities is CNS toxicity, because again, it is very common in people over 60, can cause hallucinations, seizures, confusion, agitation. So like patient has a fall, they get a urine scent, it's positive, they get started on Cipro, and now all of a sudden they're confused. I mean, you could have avoided all of that by not sending the urine or not starting a quinolone. Next slide. So again, in conclusion, bronchocomplicated infection, cystitis, bronchitis, sinusitis, definitely try to avoid it when possible. And if you have to give it for a complicated, severe infection, you should really weigh the risk versus benefit in that setting.
And also, so Ramzi, adding just you have to document that. You should. There are black box warnings here. You need to document this
Yes.
in the patient's chart. Risk benefit discussion, and don't forget that they can't be taken with dairy products, calcium, magnesium, iron. They won't be absorbed. So
Yep.
don't forget those things.
Thank you for adding that.
All right, I guess it's me again. I have the honor of talking about MDROs and EBPs, enhanced barrier precautions, everybody's favorite subject. I know that a lot of people are, you know, it's generated some controversy, and a lot of administrators say there's a lot of cost involved. We'll talk about a lot of those details and give you our honest, opinion. So MDROs are a problem, right? This is one of the major problems with COVID. We took our eyes off other problems as we needed to, I suppose, but we have seen a resurgence of multiply drug resistant organisms, and it's going to get worse. All right, facilities that haven't had any carbapenem producing organisms, for examples, you're going to see them, and those that haven't had Candida auris, you're going to see it. These are coming. So what do we call it? What is an MDRO? There's different definitions. Basically, I like to say it's often resistant to 3 or more classes of commonly used antibiotics. Some people say it's 1. It just depends on who you ask. So there's no set in stone definition of what an MDRO, what constitutes an MDRO, but there are some general thoughts and guidelines. Certainly we worry about the nastiest ones are carbapenemase producing organisms. So carbapenemase producing CREs, and we call those CPCREs, so carbapenemase producing CRE, or a carbapenemase producing Acinetobacter or Pseudomonas. Those are all concerning. A note on ESBLs. So because of the way that ESBLs have to be reported, basically if something is reported as resistant to ceftriaxone, that means it's an ESBL. So even though it might test susceptible to Zosyn, Zosyn might be unreliable outside of the urinary tract. So keep those things in mind. So your best bet is really carbapenem for these ESBL organisms, which is unfortunate because that drives more resistance and more carbapenem resistance. We have some drug-resistant Streptococcus pneumoniae, which is somewhat of a concern as well. VRE, MRSA, you've heard about all of those. So I'll go here. Enhanced barrier precautions are another strategy to prevent the spread of MDROs, because we aren't currently winning this war, and we certainly are not. So enhanced barrier precautions. There's now a CMS regulation in place since March, saying that CMS is issuing new guidance for state survey agencies and long-term care facilities on the use of EVP to align with nationally accepted standards. So EVP recommendations now include use of EVP for residents with chronic wounds or indwelling medical devices during high contact resident care activities, regardless of their MDRO status. So this means that somebody who has never had an MDRO, who has a Foley catheter, a PICC line, a PEG tube, is now going to be on EVP according to CMS guidelines, and the surveyor is going to ding you if that's not the case in your facility, because this is incorporated into regulations. So this is what CDPH says. So CDPH has, as many of us know, they had their own program called ESP, Enhanced Standard Precautions. So that's basically being phased out, that terminology, and they're coming into alignment with CMS's EVP requirements. So what we need to follow is what CMS says about EVP. CDPH is eventually phasing theirs out or merging them. We're waiting for another update from CDPH on this. This is a really useful slide. So this is CDPH's 6 moments where you need to use EVP. I'm just going to call them enhanced barrier precautions. So morning and evening care, toileting and changing incontinence briefs, for example, caring for devices and giving medical treatments, irrespective of MDRO status, wound care, mobility assistance in preparing to leave the room, and cleaning and disinfecting the environment. So it's a risk-based approach to PPE use intended to reduce the spread of MDROs, use of gown and gloves during high contact resident care activities for residents that have an MDRO or have an indwelling device, or are at risk or high risk of colonization with an MDRO, and contact precautions are not needed. So if contact precautions are not needed, and you have a patient with an indwelling device or an MDRO when you don't need a history of an MDRO, for example, you need to use gowns and gloves with these 6 activities. So this expands the use of PPE beyond situations where blood and body fluid exposure is anticipated, which is what standard precaution says. Standard precautions always says use a gown and glove where blood and body fluid exposure is anticipated. So if you have a wound and you're changing a dressing and it's not an MDRO, you need to be in gown and gloves, whether or not the patient has an MDRO. That's been the case. That's not been the standard practice in a lot of places, unfortunately, but that is what's required. And then it's used in conjunction with good infection prevention activities. So key points in understanding EVP. So MDROs do not go away even after treatment. So, in other words, somebody who has a history of MDRO always has that history of MDRO. You can no longer go back to standard precautions for somebody who has an MDRO. It goes to EVP. All right, that's their minimal level of precautions. Some residents are more likely to become colonized or infected. You're trying to protect these vulnerable residents, and you're not limiting EVP to a specific list of MDROs. Know the MDRO risks in your facility, county, state, jurisdiction. Know when to switch back to contact precautions, because if they have a draining wound and it's a patient that has a history of an MDRO, the better part of valor is to put the patient on contact precautions until you know that that wound is no longer draining, for example. Or if the wound doesn't show signs of an MDRO, you might argue to go back to EVP, but you'd never go back to standard precautions. And be ready to flex to meet needs that can change overnight. So these needs change quickly. So once you treat somebody with an MDRO, you go back to from contact to EVP, but never back to standard precautions. And here's a decision tool that's quite handy. So enhanced barrier, residents with infection or colonization with MDRO when contact precautions do not apply. Wounds, indwelling devices, regardless of MDRO status. So during high contact care activities and risk of splash or spray, you always need that face protection, don't forget. And they're able to leave the room. And then contact precautions for acute diarrhea, draining wounds, excretions unable to contain. For a limited time period during an investigation of a suspected or confirmed MDRO outbreak. Remember, you can always preemptively institute precautions if you're suspecting an outbreak to get control of it more quickly so that your facility does not get shut down to new admissions. Other infections or conditions where recommended, and they have an appendix. The link is below. So what does when contact precautions do not apply really mean? It means that contact precautions should be used for all residents that are infected or colonized with an MDR who also have draining wounds, secretions, or excretions that cannot be covered or contained. That might mean somebody on a subacute unit with a T-piece that those are not containable, those secretions. Acute diarrhea, residents who have another infection or condition in which contact precautions is recommended. What are high contact care activities? I think you know them. In the interest of time, I won't go through too many details here, but it includes device care, okay, and environmental cleaning. Okay, Dr. Sarpel is going to give you a few scenarios.
Thank you, Dr. Asfour. And I do want to point out Marianne, our infection control extraordinaire, wasn't able to make this meeting. However, she is well versed in EVP. I'm sure a lot of you have talked to her already. So she's a great resource. And it should also be noted now that CMS is requiring EVP, the surveyors are being trained up for this. So this is something they're definitely going to look into when they come to your facility. So it would behoove everyone to be on top of it. So the example of a patient, Mrs. A, getting admitted today, 48-year-old, who sustained a fractured pelvis and a head injury when she fell off her horse. She was in the ICU in the hospital for 21 days after the accident, still in pain, still confused, is mildly combative. Her nutrition is poor. She's not really following instructions. Can't really do self-care. She's on bed rest because her pelvis still needs to heal. She has no known history of MDROs. Foley catheter was inserted because of her immobility. Skin check on admission shows some sacral redness. So, on admission, after listening to what Dr. Asfour had to say, does Mrs. A need any type of precautions? The next slide. Yes, she needs EBP because she has an indwelling device, right? She had the Foley catheter placed, and now she needs EBP for high contact care. So she is someone who would need EBP. Next slide.
I would mention that unless she had bladder incontinence, maybe we could use a PureWick device instead of
Yes,
a Foley at some point.
correct.
We,
So PureWick, if you have it, they're excellent. Obviously not indwelling devices and definitely uh, good to use. And most hospitals are moving to PureWicks these days. Next slide. Thank you. So her family comes. They actually want staff to minimize repositioning because every time they reposition her, she gets agitated. Unfortunately, she develops a full thickness pressure injury on her sacrum. The wound has copious drainage and a bad odor. So she's been on EBP, right? Because she has an indwelling Foley catheter. Now she has a wound that has copious drainage. Is it appropriate to continue EBP or should we do something else? Next slide. Well, now she requires contact precautions, right? Because she has this draining wound, you can't contain the drainage, and it's large amounts, plus she's agitated. So this is one of the times where EBP would be changed to contact precautions. Next slide. So wound care was consulted. Unfortunately, the wound is getting worse. They did a culture at MRSA. A medical provider did a nair swab, and that was also positive for MRSA. She was already on contact precautions, which you would need for MRSA drainage that's not containable, so that's great. Starts on appropriate antibiotics, starts on appropriate wound care. Now her pelvis and sacral wound are totally healed. She's still a long-term resident because of her head injury, which hasn't shown much improvement. But the wound is healed. Her Foley catheter is now out. Does she still need any precautions? Does she need contact? Can you take that off? Can she be free to do whatever? Next slide. So remember, this is a continuum, right? So at this point, she's considered colonized because she had MRSA. She had MRSA in the nose. She had MRSA in the wound. So she can come off of contact precautions, but she would still need to stay on EBP because she was colonized with MRSA. And that's just the new guidelines and recommendations. Next slide. So this is just a slide to help. This is from the CDC. The link is there. There are rollout tips to help address potential challenges. One thing that should be noted is, the EBP is thought to decrease costs. So by implementing EBP in the long term, your facility will actually have reduced costs. And if you can hit the button. Also a good point is you can reduce PPE use when you bundle all the high contact resident care activities, right? So like you're changing the briefs, you're assisting with toileting, bathing, showering, hygiene. You can bundle all that with changing the linens, for instance, and that way, you just put it on, do all those high contact activities, and then that's it. So it's one way to reduce PPE use, but this is a great tool from the CDC that you can look into. Next slide. So these are just some suggestions in how to roll it out. So obviously clear training, which we can provide and have provided, signage, which hopefully CDPH would provide, but there are other good signs out there that you can use. Can check core competencies about this, clear communication among all the staff, including your environmental staff who have to clean the room. If you have a bigger facility, maybe try start in one unit and then go from that unit to the next unit and just kind of do a rollout that way. Obviously, you do need to monitor shifts in staff for compliance and then provide education. Definitely stay in touch with your local DPH. CDPH is we'll be putting out a new webinar. I believe it's next week, but again, try to attend those, listen to those, because I'm sure they will be updating EBP as we move forward. And again, communication, very important. And definitely got to be compliant because, as I mentioned, the surveyors are already being trained up for this. We've already heard about this. So that is something that you need to stay on top of. Not listed here is communication with the family is important. There are some letter examples out there that you can provide the family. I think CDC has one. Some other state DPHs have one. We've modified one, so if you need one, you can always contact us and we can provide that for you. So communicating with the family is also important. And if they're going to be doing a lot of these high contact care themselves, then you can educate them on gowning, gloving, etc. if they're going to be providing the care. So that's again communication and setting expectations. Next slide. This is just a nice short video from the CDC. The link is there. It's also available in Spanish. They just have basic info, simple, clear graphics. You can share it with the family just so they know what's going on. Next slide. Again, out of the scope of this talk, but other things you can do to reduce MDRO risk is skin decolonization with chlorhexidine bathing, and also nasal decolonization with Nosine, which is being used more and more in facilities and hospitals. So those are other things if you have a particular problem or an outbreak in your facility that you can consider. Next slide. So we just want to acknowledge the people that helped us, and these are our emails for Dr. Asfour and myself, as well as Marianne. As I mentioned, we do put out a newsletter monthly that kind of hits on the hot topics of long-term care. You can contact us through Capsid Consulting if you want to subscribe and get those. Newsletters. I know some of you are on our subscription list and are getting it. And one thing I did want to mention before we open it up to any questions that I didn't mention earlier in terms of shorter is better. One of the things that we hear a lot from IPs and facilities is this is what the hospital discharged the patient on. They wanted the patient to get 10 more days of antibiotics or whatever. That's something that we hear a lot. Well, now that the patient's in your facility under your care, you're the one that's responsible for that patient, as well as antibiotic stewardship and infection control. This is when you can contact us. Who knows if that patient even saw an infectious disease physician in the hospital? You have 2 board certified infectious disease consultants at your disposal. So, patients coming back and they're on 10 days of Cipro after receiving, 5 days of ertapenem in the hospital, and you're questioning why, reach out to us. We can do a quick review of the cultures and discharge summary, and definitely kind of can give advice in shortening the therapy. So that shouldn't be a barrier to shorter treatment, and you can always utilize us. I think I don't know if Dr. Asfour, if you have anything else to add. I'm not sure if we have any questions in the chat room.
I think that the providers and any providers out there, you guys should be contacting us a little bit more often. We can definitely help in difficult situations. Running by we actually see your prescribing practices and on occasion, and instead of reaching out to people individually, we thought we'd do this webinar just to talk about antimicrobial use, reducing quinolone use for all the reasons that Dr. Sarpel mentioned, and we can definitely help support you when a patient is discharged. Sometimes your patient will go to the ED because they aspirated, right? They aspirated. That's the most likely thing. They come back from the ED. They don't even get admitted, or maybe they get admitted for a day. They come back the next day on treatment for UTI because they did a UA and they found that there was pyuria. So they don't have a UTI. They didn't have a UTI. They had a cough when they came in and aspiration, or they choked on their dinner. These are important things. And for the nursing staff that's calling the doctors in the nursing homes about change in condition, you need to provide that kind of information. What was the patient doing when the patient had a fever? Was there sign of aspiration? Was the patient having any symptoms of a urinary tract infection? Especially if it's a covering doctor that doesn't know the patient very well. This is a patient who would be able to say that they had pain when they pee, or this is a patient who doesn't have that ability. So you need to give them context, which can be really helpful. So keep that in mind. If anybody has any questions, just pop them into the Zoom chat. I don't see any questions there, which either means that we weren't doing a good job, or we told you everything that you need to know, except for what's happening with Stormy Daniels right now in the courtroom in New York, which not many of us are paying attention to. I'm trying to be a little funny.
I did want to point out that we are recording this, and so if you're an admin or an IP from a facility and you have a medical provider that wasn't able to join, you can always share the link with them, and they may be the most interested in the first half of the talk, but you can always share this with them, and we are recording this as well.
But I think that educating the providers on enhanced barrier precautions is important to making sure that
Yes. Yep.
everybody's on board, realizing the importance of it, and the fact that CMS has now made it a requirement. So participation had been optional, or sort of optional before, and I
Right.
think the CMS has taken that option away and made it essentially a requirement.
Oh, there's one.
All right.
Someone's asking if the slides will be available later. Yeah, we can send out a PDF. Arlene, we can send it to Arlene, who can distribute it.
All right. Well, thanks everybody. I hope you have a great rest of the day, and please do reach out to us with any questions. Thanks.
Thank you.
Recording stopped.